Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through GI pharmacology. Now, we're splitting this into two videos. The first video, this one, is going to be peptic ulcer disease and gastroesophageal reflux disease. And then the next video, we're going to go through nausea, vomiting, constipation, diarrhea, and BDC. Let's go ahead and start talking a little bit about pathophysiology for GERD and peptic ulcer disease. So GERD, gastroesophageal reflux disease, is very common. Millions of people have it, and it's a condition where the lining of the esophagus is exposed to the acidity from the stomach contents. What does that mean? In our stomach, we have gastric juice. That gastric juice helps digest the food we eat. It also helps sort of sterilize the food we eat so that we don't get harmed by everything that we eat. This gastric juice or gastric acid is very, very strong, very potent, very toxic. The esophagus can't tolerate being exposed to that. So if that juice comes up into the esophagus, which it's not supposed to, that would cause gastroesophageal reflux disease. Peptic ulcer disease is a little bit similar. Peptic ulcer disease, again, involves that really toxic gastric juice. However, in that case, the gastric acid, the gastric juice, is able to deal with the stomach is able to tolerate that juice on a regular basis in all of us because we have a protective lining. If that protective lining develops a hole, develops an ulcer, now that gastric juice can get through that lining into the tissues underneath and start to cause pain and other problems, and that is peptic ulcer disease. Peptic ulcer disease can also be divided into peptic ulcers and duodenal ulcers. We're not going to get into that. This is just pharmacology. I will tell you, because you could see this on a pharmacology exam, the most common causes of peptic ulcer disease are NSAID use, because NSAIDs, if you remember from our anti-inflammatory lecture, NSAIDs break down the protective stomach lining, or at least they block the body from building up that protective stomach lining. Plus, the second most common cause, not the second most common, but the other of the two most common causes, I don't know which is more common, would be H. pylori, Helicobacter pylori, which is a bacterial infection. When a patient has either of these conditions, we do have some non-pharmacological interventions that we always begin with. These include reducing smoking if that's an issue, reducing alcohol if that's an issue, reducing weight if that's an issue, avoiding spicy foods, not eating before bedtime, and not lying down flat right after eating, plus avoiding NSAIDs. So in the pharmacology world for peptic ulcer disease and GERD, we're going to have three primary drug classes, and these are PPIs, H2RAs, and antacids. Each of these have their own unique aspects and their own time of when we use it. We're going to start with PPIs because these are the most potent. Before we go any further, I do want to point out everything we're about to discuss is all over the counter. The next three drug classes, PPIs, H2RAs, and antacids, are all available over the counter, but keep in mind, in the hospital setting, every one of these still needs a prescription. So starting with the PPIs, proton pump inhibitors, these are drugs like omeprazole, pantoprazole, esomeprazole. These medications work by blocking proton pumps. Proton pumps pump out that acid, so it blocks that, so there's less acid. If there's less acid, then the whole problem of the acid getting through the tissue in peptic ulcer disease or getting up into the esophagus and exposed to that tissue in GERD, that problem goes away. So, and I say goes away, it's a little more complicated than that, but again, that gets more into a deep pathophysiology discussion. It's where the body is able to heal itself when it's not under constant, so to speak, attack from this gastric acid. Again, the proton pumps inhibitors block the proton pumps from pumping out that acid, so there's less acid. The environment is less toxic. We use this for GERD. We also use this for peptic ulcer disease. Patients can have or develop rebound symptoms if they take this long term. What's long term depends on the patient. Generally, because of this, we don't recommend patients take this medication for more than 4 to 8 weeks. I've seen some of the nursing school textbooks say up to about 12 weeks, but definitely nothing more than that. If they do take it more than that, there's a good chance they're going to get hooked on this for the rest of their life, meaning that if they ever stop taking it, the issue is going to immediately come back. And if you understand a little bit of what I explained, the patho, it would make sense that if a patient had a lower gastric acid level for a long time, the body won't tolerate going back to that really harsh level. PPIs are stronger than H2RAs. That doesn't mean they're better. It just means they're stronger. So if a patient is otherwise healthy and I want to knock out this issue quickly, I might go with a PPI. If a patient has other issues going on, then maybe I'd rather go with the more gentle medication, which is the next one we're going to talk about, the H2RAs, because if that gets the job done, we'd almost always rather the more mild medication if it will get the job done. Again, these are available over the counter. If a patient is taking these long term, especially if they're a female post-menopause, you must recommend that they also supplement with calcium and vitamin D on a daily basis to reduce the risk of osteoporosis and fractures. Next class we have are the H2RAs, or histamine 2 receptor antagonists. These drugs include famotidine, ranitidine. These are available over the counter. Pepcid, Zantac, that was in the news about 5 years ago where a bunch of it got pulled off the shelves because of carcinogens in there. But anyways, these are the different drugs we're talking about. You should, if you've already watched our upper respiratory pharmacology video, you may have seen drugs like cetrizine and fexfenadine. These also end with the DINE because these are also histamine receptor antagonists. Those were histamine 1 receptor blockers, more commonly known as Claritin and Allegra. These are histamine 2 receptor blockers. These are Pepcid and Zantac. They don't do the same thing, even though they have almost the same drug class. The mechanism of action here is that these block the histamine 2 receptors, which reduces the gastric acid, and it reduces how acidic it is. It reduces the volume and the acidity of it. What do we use it for? We use it for GERD, and we can also use it for peptic ulcer disease. For peptic ulcer disease, actual peptic ulcer disease, we generally prefer to go with a PPI. For GERD, generally we're going to go with a H2RA unless the patient's perfectly healthy. Otherwise, then we might be more comfortable going straight to the PPI, which is more powerful. These medications can be used daily, which is the only way we use PPIs. But the H2RAs, can also be used PRN. The PPIs are not used for PRN. They're taken every day. But these can be used PRN. If you're having patients having some indigestion, some heartburn, they could go ahead and take some PRN H2RA. However, more commonly for PRN is going to be the next drug class, which I'm going to get to in a second, which are the antacids. Ideally, the H2RAs, same as the PPIs, should not be used for more than 4 to 8 weeks. Again, some books say up to 12 weeks. And again, this is over the counter. I'm going to skip this for 1 second, this next drug class, because I want to get to antacids. Antacids is a pretty large drug class. It includes some famous ones like Tums and Alka-Seltzer. And these drug works by very quickly neutralizing the gastric pH. Remember, the patient that has peptic ulcer disease or GERD, the gastric acid is hurting the tissue, either in the esophagus or what got through the stomach lining. So we want to quickly neutralize that. However, that doesn't last very long, and that's not a permanent solution. So these drugs are a PRN option. They are not curative. They are for symptom relief only. You take it, and usually within 5 to 15 minutes, the pain goes away because you immediately and quickly make the gastric acid a lot more alkaline, so you reduce the toxicity of the gastric juices. This medication, because it rapidly and dramatically changes the pH in our stomach, we should not take it with any other medications. And this is a super common nursing pharmacology test question, that we don't want to take these antacids with any other medications ever. Because every single PO medication, I'm talking specifically PO, every PO medication is formulated by the pharmacology companies and the chemists and the pharmacists to be able to work in the exact environment of the body. And we have a pretty good idea of what's the pH, what's the environment in the stomach. And it's calculated and it's developed and formulated our medications to work in exactly that environment. If we go and take an antacid and we dramatically change the pH in the stomach, that can have a significant effect on any pills that we take. And it might be a good effect, it might be a bad effect. We don't know because it's not meant to be given in that environment. Therefore, do not give any medication with an antacid. That's a very common nursing test question. The answer is always don't give them together. Generally, depending on what book you look at, it's going to say either 1 to 2 hours before or 2 to 4 hours after giving any antacid is when you'd be able to give another medication. The side effect of these medications depends on which drug we're talking about. I did list them all here on the sheet in front of you. And obviously you can get these sheets from Bullet Point Nursing, but I'm not going to go through each of these, but each of them do have their own side effects. I have seen these in nursing test banks, so please go through these real quick. Aluminum-based antacids can cause constipation. The magnesium ones can cause diarrhea. Sodium bicarb can cause alkalosis or sodium overload, and calcium carbonate is known to cause constipation, and it can also cause, obviously, hypercalcemia. A overdose of any of these can cause metabolic alkalosis. In fact, the overdose of the antacids is one of the only causes of a patient developing metabolic alkalosis. Plus, obviously, because most of these have different electrolytes in them, it can cause electrolyte imbalance. Again, real quick to wrap it up, this medication is our go-to PRN for most patients. It is available over the counter. It does give them very quick symptom relief, but it does not fix their issue. But it does work to help patients that have not consistent pain, but intermittent random pain to do with heartburn. Now let's get back to the 2 drugs that we skipped. We talked about PPIs, H2RAs, and we talked about antacids. That's the bulk of this lecture, but there are 2 other drugs I want to discuss. The first drug class is going to be a pepsin inhibitor, and this is sucralfate. This is not a very common drug. It works very different than the other ones. All the other ones that we discussed so far help deal with the actual gastric acid. This one actually focuses on the other side, on the ulcer side. And what it does is it creates a coating over the ulcer, like patching up a pothole in the road. It patches it up so that the gastric acid can no longer get down into that hole and through that hole to the tissue underneath, which is the real problem. But instead, it creates a coating over it and allows that ulcer to heal itself. Again, this should not be taken for more than 4 to 8 weeks. The big downside to this one is that it's taken four times a day, which we already know. Anytime you take a drug a whole lot, it decreases the compliance. Next, we have the PGE1 analog, the prostaglandin. This drug is called misoprostol. You've seen this in the news over the last decade or so many times. This is one of the two abortion drugs in the United States. But today we're not talking about it for an abortion. We'll talk about that in reproductive health. Today we're talking about it specifically for the use in preventing peptic ulcer disease. So this is a synthetic prostaglandin that replaces the elements that are necessary for the stomach, for the body to build up that protective stomach lining. This replaces those elements that are necessary for the stomach to build its own protective lining that NSAIDs block. Remember, we said in the very beginning, NSAIDs can cause these peptic ulcers because it blocks the stomach from building its protective lining. This can help that. So what do we use it for? We use it specifically to prevent ulcers in patients that are taking long-term NSAIDs. In general, we don't want patients taking long-term NSAIDs, almost primarily for this reason. But if they are going to be taking long-term NSAIDs, such as an RA patient, rheumatoid arthritis, this would be a medication we may give that patient to take with it to reduce that risk of NSAIDs. I personally have never given this medication. This is a complicated medication, so you'd have to have this done by probably the rheumatologist or whoever prescribed the long-term NSAIDs and knows exactly what the risk versus benefit of being on that medication and the risk of ulcers. Obviously, this could also be prescribed by GI if a patient's coming in with that risk of developing ulcers. The side effects of this medication are GI effects plus uterine cramping and bleeding, because we said this is a very powerful reproductive health medication. This is absolutely teratogenic because this does induce abortions in pregnant females. And again, this is the abortion drug in the United States, in addition to being used today in GI for patients that are at risk of long-term NSAIDs. Finally, just the last note I want to make is what you should see on your screen right now. Peptic ulcer disease that is caused by H. pylori, which we said in the first 5 minutes of this lecture, that is caused by H. pylori, in addition to whatever medication in today's lecture they're going to be treated with, they also need to get antibiotics. Usually it's going to be 2 different antibiotics, but they also need that because it is, at the end of the day, a bacterial infection. In fact, anyone that comes in with suspected peptic ulcer disease, we are going to test them for H. pylori. Very interestingly, it's actually a breath test that we do, but we're going to test them for H. pylori. And if it is H. pylori, in addition to getting these medications, the peptic ulcer disease medications, they're also going to get antibiotics. Here are the references for today's lecture. If you have any questions, please reach out. Please subscribe to our channel, like our video, and have a great day.